So if we look at the nasolabial folds, of course, we know that the nasolabial folds are one of the most requested facial indications for fillers. And as we know, it's not really the fold, it's actually the descent of the cheek that is the problem. So ideally, we would start with lifting the cheek and then focusing on the fold itself. But of course, she already has very good cheeks, and there's a little bit of extra volume because of the infraorbital nerve block. But over here, the nasolabial fold is still visible. So what I will do is I will show you the technique that I use for direct treatment of the nasolabial fold. So that means moving with the needle to the maxilla and correcting maxillary bone loss, bone resorption. I'll do that with a needle. The facial artery is running usually just lateral to the fold in the subcutaneous layer, in the subcutaneous anatomical layer. So if I pull up the tissue, then move the cannula to the periosteum, the risk that the needle would actually be intra-arterial is extremely low. Another precautionary measure is that when I inject, I only inject the maximum of 0.1 ml in a bolus. And then I reposition the needle tip to another place. And so again, a maximum of 0.1. So in the highly unlikely event that the needle tip would be intravascular, the maximum amount that I would be injecting is 0.1. Of course, that could have a schema of a area as a sequelae, but if the patient would need 0.3 cc's and I would inject 0.3, of course, if that would be in an artery, then the effects would be devastating compared to if it would be only 0.1. So I have a syringe of non-diluted calcium hydroxyapatite and a 27 gauge needle. And what I usually do is start from below and work my way up. So even this little wrinkle over here, I can use for a very superficial injection, 1, 2, 3, of calcium hydroxyapatite. And I make sure that the gray of the needle is not visible. If the gray of the needle is visible, then I'm too superficial and I might see this yellowish discoloration. And I give a retrograde linear thread of about 0.05 slowly. My second entry point will be, this is the length of the needle. The second entry point will be just a little bit overlapping the first retrograde, and I advance the needle. So it's a very slow advancement. See, now this is becoming a bit gray, it's a bit superficial, so I go back a little bit deeper, and the needle is just at the dermal-subdermal junction. You see, it's in the subcutaneous fat. I see that because when I move the needle, it's actually not pulling the skin with it. So this is subcutaneous. And I'm medial to the fold itself. 0.05, I'm injecting again. Retrograde linear thread. So that was from here. This is where the retrograde is. And now a little bit overlapping the first, I'm advancing the needle again, superficially, at the dermal-subdermal junction, more or less. And of course, I have to make sure that when I start injecting, I pull the needle backward. Because this is also where the facial artery is located, is in the subcutaneous tissue. Over here you see a little bit of a bump now. That's fine, I just mold it and make sure that I even it out. Sometimes when there's not really a lot of bone, I just ask my patient to open up her mouth. Can you open your mouth? and put one finger inside and one finger outside, and I massage the product. I press it, and sometimes even put a little bit of cream in between my thumb and the skin, so you can actually, let's say, brush over the skin. But now I'm just kind of pinching. It's not too hard, but I want to purposely even out what I've injected. Then the last entry point is over here, 1, 2, 3. And I advance the needle towards the ala. And again, careful retrograde linear thread. And then I make a fan when I get to the alar area. And I inject even less than 0.05 per retrograde. Can you open your mouth again? So this is the dermal correction of the nasolabial fold, or the dermal subdermal correction of the nasolabial fold. The second level is the maxilla. Because of bone resorption, of course, we know that the maxilla, that the nasolabial fold deepens over here. Therefore, I put the bevel down and I want to advance my needle to the piriform aperture, just lateral to the piriform aperture. I have a soft touch to the periosteum now. I give a small bolus of maximum 0.1. I stop injecting, I retract, I reorient, a little bit more medial, and re-advance. Soft touch again to the periosteum, and a small bolus. 0.05, maybe maximum 0.1, and here another 0.05. Sometimes the periosteum gets stuck in the needle and you get a little block. So what you can do is express a little bit of product, and then you can use it again after you've expressed it. Okay, so one more deposit at the maxilla, soft touch to the periosteum, 0.05 in this case. All right. Can you open again? So I'm kind of molding the product, and I'm always molding from lateral to medial. The reason I do that is I don't want the product to accumulate in the nasolabial fat compartment, because that could make the nasolabial fold actually worse. So as you can see, it's now starting to swell a little bit, so it looks more corrected than the final result will look. In total, I've injected less than 0.5, so it's about 0.4 that I've injected.